I was always very fascinated by the history of heart surgery. And one of the reasons was I grew up with it. I was born the year the National Health Service started, 1948. And at the time, people were thinking about heart surgery, but didn't know how to do it. And the Johns Hopkins in Baltimore, where the AATS has just been, was one of the hotbeds of discussion as to how we can operate on the cardiovascular system. Oh, that's not what I wanted. That's what I wanted. William Osler here, in fact, came from Johns Hopkins to be professor of medicine in Oxford. So the two have been closely linked for many years. And I've visited Hopkins very many times, and they have a great wall with lots of pictures on them. Denton Cooley, of course, started there. So this is not a bad quote to start with. In science, the credit goes to the man that convinces the world, not to the man whose idea it is first. And we all know about that. We're pinching other people's ideas all the time and pretending that we made them up. But this was the great man, Alfred Blalock, who came back from World War II, and he was a student in Hopkins in 19 and started a cardiovascular program with Dr. Cooley as a junior resident in the 1940s. And of course, he came up with this idea, or did he? In fact, it was a pediatric cardiologist who actually came up with the idea, and they fell out very badly. The very first attempt to deal with a heart valve was by this gentleman, Elliot Cutler. And the problem was rheumatic heart disease. It was the scourge of the Western world, Africa, and everywhere else. Rheumatic heart disease meant narrowed aortic valves, narrowed mitral valves, leaking tricuspid valves, and desperately ill young people. So they wanted to do something about it. And they had the concept, without any vision in the future of being able to do open heart surgery on a machine. They had the vision of sticking their fingers into the heart and opening up the valves. And it was actually an Oxford guy again who first did that in the UK. Henry Soutar was a surgeon in the Royal London Hospital. And he heard about Elliot Cutler attempting to open up rheumatic mitral valves and decided to do it himself. Round about the same time, one of the great British pioneers, Russell Brock, took a scholarship to the US to look at thoracic surgery. And in just the same way as I went to Dr. Kirkland in 1981, all the British used to go across to America to see the great guys and learn from them. And Brock attributed his great career to the thoughts that he had as he watched thoracic surgery at the Barnes Hospital. The thing that actually made the Europeans and the Americans come together to think about cardiovascular surgery was World War II. Because Michael DeBakey was the head of the medical services for the US in Europe, and he met with Dwight Harkin, who we'll come on to, and Brock, and they used to sit around drinking beer and fantasizing about how they might be able to operate on hearts in the future. But this was an important contribution from DeBakey. Way back in 1934, he designed a pump, a roller pump, to assist with blood transfusion, to speed it up. And of course, this became the basis of the roller pump for the heart-lung machine many years later. A lot of things had to come together before you could actually attempt open heart surgery. And not least was the development of antibiotics. Without antibiotics, you really cannot safely and reproducibly do thoracic and cardiac surgery. Blaylock went to become chairman at Hopkins and started a cardiovascular unit. DeBakey was across in World War II. Cooley went after World War II to Hopkins. So all of these things are beginning to come together. Cooley did the first ever aneurysm operation while Blaylock, his boss, was out of town, and became extremely notorious as a very effective technical surgeon. And then Brock and Harkin came together in a field hospital, and things are starting to come together. Now, when I wrote Landmarks in Cardiac Surgery, I had the great privilege of communicating with Harkin, Oswald Tubbs, Charles Bailey, all of these guys just before they died. And Dwight Harkin sent me a very nice signed copy of his original paper. It was Harkin's work taking bullets and fragments out of the pericardium and the heart that actually proved to people that you could operate on the heart. Before that, as Bill Roth had said in the 18th century, anybody who thinks about operating on the heart must be completely mad. And as you can probably see, a lot of the people that still do operate on the heart are completely mad. Not least myself. It wasn't actually Blaylock that came up with the Blaylock-Taussig operation. Helen Taussig went to him and said, we've got so many blue babies with low pulmonary blood flow through congenital heart disease. Can you think of any way of improving the blood supply to the lungs? And in the laboratory, Vivian Thomas, who was just a technician but a very good surgeon, was joining subclavian arteries to the pulmonary artery for another reason. And it was through Helen Taussig and Vivian Thomas that Blaylock did his first Blaylock shunt. And actually, Vivian Thomas was the great technician. Alfred Blaylock himself wasn't a great operator. He was a guy that inspired his colleagues. And this is a quote that Brock made about Blaylock, saying that he was the professor, inspired those around him. And here's the young Denton Cooley at the time. Denton Cooley gave fluids to the baby in that very first Blaylock shunt. Now, things then started to kick off, particularly in the States. And this is Charles Bailey, who's a curious character who gave up cardiac surgery to be a lawyer, which I guess a lot of people are thinking about doing these days. But this is the year I was born, which makes me very old, like Tyrone. And previously, these guys have been putting their fingers into the atrium and just using the tip of the finger to open up the mitral valve. Charles Bailey tried to take it a step further and produce instruments that you could put on your finger to open up the valve. But herein lies a very interesting story. This is drawn at Bailey's instruction by Walt Disney. Walt Disney in World War II was an illustrator with the US Army across in Europe. Harkin and Bailey and various other people got to know Walt Disney. And when Walt Disney went back to the US, he became a medical illustrator. And this was Charles Bailey's concept of the mitral valve with the Cordy, etc. And actually, Charles Bailey, before he died, sent me a photocopy of the original one of this to go in Landmarks in Cardiac Surgery, which was obviously just fabulous. But yeah, there are distinct similarities. And most cardiac surgeons, of course, work with both. I've only got 2 slides with writing, and this is the second. All the rest are pictures. So early post-war years, Lord Brock, Russell Brock, as he was in 1947, got Blaylock to come across to London to demonstrate the blue baby operation. And they did that with great aplomb. And Blaylock gave a lecture in the Great Hall at Guy's, which went down extremely well. And at the end of the lecture, a spotlight came on in this ancient Great Hall on a nurse wearing very fine blue uniform and white hat, as they did, with a baby on a knee that had had a Blaylock shunt a couple of days before. And the baby with tetralogy had been very blue and was now pink. So that was massive drama, and most of the embryonic British cardiac surgeons were in the hall listening to that at the time. So that kick-started interest across in London with Brock and colleagues on getting moving. Then DeBakey became chair of surgery at Baylor. Cooley went with him. Mitral valvotomies started going on all over the place in '48. I did this for a meeting to celebrate Denton Cooley's, the slide was a meeting to celebrate Dr. Cooley. So I mentioned that Cooley met one of the head nurses and got married. Not particularly applicable to this talk, I don't think. It was in Hopkins, as when he was a resident, that Cooley started aortic surgery. As I say, when his boss was away, Cooley was a much better technician. Hopkins attracted a lot of cases. Syphilis, all sorts of stuff was the cause of aneurysms in those days, and Cooley was just allowed to get on with it. Then, of course, the great step forward. John Gibbon, one night as a resident, sat with a girl dying of pulmonary embolus all night and had the concept that if you could take out her blood and put oxygen into it and put it back, you could have kept her alive, and thought about taking the embolus out the pulmonary artery. So he worked with his wife here on the development of a heart-lung machine. And it was in the early 50s, when I was around about 5 or 6, that they attempted the first open heart operations with cardiopulmonary bypass. And actually, they didn't go very well. Gibbon had one success. He only had one success with an ASD, with a heart-lung machine. And it was this girl, and this is a picture of the two of them together 10 years later. But he became so dispirited with attempting open heart surgery with cardiopulmonary bypass that he walked away from it. And I often say, if heart surgery didn't exist now, we would never be able to start it. Because the mortality of all these operations in the early days was absolutely extraordinary. And to do heart surgery, you had to be the sort of guy that would go to work, attempt 2 operations, have 2 deaths, and do it all again the following day. Now, this is Walt Lillihei is a gentleman I also got to know very well just before the end of his career. When I was a young man, and via Kirkland and so on, I got to know a lot of these pioneers. He had the concept that you could operate on babies and do a good job inside the heart by connecting up an infant with its parent. And this was the famous cross-circulation operation. And he did, I think, 34 operations using cross-circulation. Until he himself, Lillihei himself, actually became so worried about the potential for 200% mortality, for damaging the donor and losing the baby. It never happened, but they were very worried about it. This is, of course, the scene in the operating theatre when he did his first cross-circulation operation. And over here, with virtually nobody looking at him, is the parent, and they're operating on the baby's closing a VSD over here. But this was a fantastic contribution. And one thing it showed everybody was that there was a difference between operating with this technique and with a heart-lung machine. The difference was if a child or a more elderly adult went on a heart-lung machine, and had an operation that took a couple of hours. When they came out of the operating theatre, they would have wet lungs, the kidneys would go on the blink, they had the post-perfusion syndrome. Now, the kids operated on using this did not have the post-perfusion syndrome. So that was actually a very early clue to what we call the damaging effects of cardiopulmonary bypass. So Lillihei, going away from cross circulation, produced his own machine in Minnesota and pursued cardiopulmonary bypass and open heart surgery that way. Just up the road in the Mayo Clinic, Kirkland started a cardiac surgical program, and for several years, the two programs in Minnesota were the only open heart programs in the world, but they showed that open heart surgery was possible with a bypass machine. Here's another machine in 1958. This one came from Walt Lillihei. If you're not immediately sure about what that machine is, that's a pacemaker. That is what a pacemaker looked like in 1958. How did the pacemaker come about? Well, Lillihei, doing his congenital heart operations, frequently had problems with a bundle of His. And he asked his physiologists in a straightforward physiology lab, they had something called a grass stimulator that stimulated frogs' legs and made them jump. So Lillihei said, can you try and make me something that will stimulate the heart if I've rogered the conduction system? Because in those days, they had no idea where the conduction system was. So that was the pacemaker. Great Britain were a bit slow to get started, but as I say, after Blaylock visited London, Brock got started at the Royal Brompton and at Guy's, and he had Donald Ross with him, so our end got going. At the same time, lots of other surgeons were not convinced that the heart-lung machine was the way to go because of the damaging effects of cardiopulmonary bypass. With the post-perfusion syndrome, you could do a nice operation and then the patient would die of the complications afterwards. So there were other ways of attacking the problem. You could cool the patient, snare the KV and do a smash and grab operation inside the heart. Bigelow, a Canadian, started the proposal for deep hypothermia. Bigelow, coming from the north in Canada, was used to frostbite and cooling and did lots of experiments on that. And so the prospect of cooling was used, dropped the systemic temperature by 7 or 8 degrees, and that prolongs the potential safe period for stopping flow to the brain. So that basically, they said, well, we'll cool and we'll do a smash and grab operation. And Charles Drew at the Westminster Hospital here did the same. It was never very satisfactory. So, in short, it just got more and more and more complicated, but eventually more and more successful. And the most successful group in the early days in the UK were the Hammersmith Hospital. And I went to train there, having become a general surgeon in Cambridge. I went to the Hammersmith to train when Bentall was there and the great cardiologists, Celia Oakley, Shillingford, and so on. Dennis Melrose was still running the bypass machine, and they were great pioneering days. And the Hammersmith did very well with it. And the other thing the Hammersmith did, of course, was started cardioplegia. And against the background of all this, you couldn't always repair a heart valve, so people started trying to replace the heart valves. And as you can see, all sorts of weird and wonderful contraptions emerged, and most of them worked. There's a valve there. I once wrote a paper entitled Longest Surviving Prosthetic Heart Valve that was published in Journal of Thoracic and Cardiovascular Surgery. I did a reoperation on a patient with a rupture, a huge ascending aneurysm that had had a Starr-Edwards ball valve in the aortic position for, I think, 44 years. Something absolutely ridiculous. And the valve was as good as new. And I kept the valve in situ, not wanting to overcomplicate the whole thing. The thing had worked perfectly for 40-odd years, so I replaced the ascending aorta and so on and kept the valve where it was. The patient lived for about another 7 years. So that was a very long-standing prosthetic heart valve. This changed everything, really. Coronary angiography started at the Cleveland Clinic with Mason Soanes, and there's Mason Soanes in his clinic. When I was a young general surgeon, I invented a general surgical thing, and the company that made it sent me all around the world showing people how to use it. And I went to the Cleveland Clinic, and I wasn't terribly interested in general surgery, but I knew about Mason Soanes and Favaloro, so I found myself to the cath lab and met up with Soanes and watched him do some angiograms. And it was absolutely true. He used to stand there and smoke in the middle of every angio. He was a very, very heavy smoker, and he died of lung cancer, needless to say. But the beginnings of angiography changed everything. As soon as you could make good diagnoses, you could do better surgery. And as early as 1962, Michael DeBakey was working on left heart bypass and assist devices. Because in those days, a lot of patients simply died of low cardiac output state after the cardiac surgery. And if you had a machine to keep them going, they wouldn't die. This is his very first patient. 1966, the year I went to medical school, first LVAD success. And I remember the news about it. Because I decided I wanted to be a heart surgeon when I saw a program called Your Life in Their Hands when I was age 7, which came from the Hammersmith Hospital, and it was about the Hammersmith trying to start cardiac surgery. And I was living in the back streets of a northern steel town, and my parents got a little black and white television set, and there it was, Your Life in Their Hands, and I said, I'm going to be a heart surgeon, don't want to be a proper doctor. I always wanted to be a heart surgeon. And of course, these landmarks on the way kept me interested. And the very next year, we all heard about the world's first heart transplant. And this is the front page of the Cape Town Argus the day after Barnard did his transplant. That's the donor, Denise Darville. She was out shopping with a mother who was killed by the car outright. And Chris Barnard, who I got to know very well one way or another. I used to go to South Africa quite a lot, put the heart into Washkansky. And a little anecdote, 25 years later, I was invited to a ball to celebrate the first heart transplant. And Chris Barnard, at the time, had just married his second wife, who was a stunningly beautiful model. And I was Jack the Lad in those days as well, so I was in a white jacket and black tie, and the Cape Town Argos took a picture of me with Mrs. Barnard and put us on the front page of the Cape Town Argos, and they took a picture of Barnard with Mrs. Washkansky, who was a very elderly lady then, and her picture was on the inside. So, you know, I've been in trouble all my career, as most of you know, but there's no wonder. I didn't include the pictures. Anyway, then Norman Shumway, as you know, who was very disappointed that he hadn't got there first, got on and made transplantation realistic. And then, of course, the great Dr. Cooley in Houston came up with an artificial heart. He pinched DeBakey's artificial heart engineer, Liotta. And that's how they fell out. Dr. Cooley put this total artificial heart into Haskell Karp on a day when he knew Dr. DeBakey had gone to Washington to talk about mechanical circulatory support. So Dr. DeBakey, the most eminent cardiac surgeon in the US, is in the NIH. and he gets a telephone call from some well-meaning individual saying, "Did you know Cooley's just implanted the artificial heart that was developed in your department?" And that was why they fell out, and they fell out for life until Michael DeBakey was 98, 99, and they came together. And I must say I was there when they came together, and it was terrific. The story here is that here's Haskell Karp the day after the surgery, extubated. He was only extubated for 20 minutes to take the photograph. And the Texas Heart Institute has very fine carpets in their intensive care unit. But was total artificial heart ever realistic? Is it realistic now? I don't think so. You needed all this. This was the drive console, the gas cylinders and everything else. And Karp did get a transplant, but died the next day. Coronary surgery started in the Cleveland Clinic. This is Mason Soanes looking over Rennie Favaloro's shoulder when he's doing a coronary bypass, and this is the angiogram that shows the blocked coronary artery, and there's the bypass graft. And of course, this started an explosion in cardiac surgery. It happened sort of when I was getting interested in cardiac surgery. For me, coronary bypass surgery has never been terribly exciting, I have to say. I think you feel the same, Tyrone, don't you? But it was a great thing. It was great. And here are the two. Favaloro left the Cleveland Clinic, having started realistic coronary bypass surgery in Cleveland. He left and went back to Argentina and set up his own institution and a charitable organization. And they ran out of money, and he came back to the Cleveland Clinic to see Mason Soanes when he was dying of cancer, and then went back to Argentina and blew his brains out. He got depressed about the situation the way, all of us are depressed about the National Health Service, but I'm not going to blow my brains out over the National Health Service. Now, I threw this in to indulge myself. When I actually got started, as I say, I trained in general surgery in Cambridge with Roy Kahn, and we started doing liver transplants at that time. I just used to love to operate, and I used to operate all bloody day and all night. And I became Oswald Tubbs, the pioneer's last resident. But in the Brompton, in a dusty old cupboard, I found Lord Brock's boots. I put a skeleton in there just for the sake of the picture, but these were very, very important to me, and I purloined Lord Brock's boots, and I used to walk around in them. I made them my boots. And it was a damn good thing that I did, because one night the great Matt Paneth, who was 6'6", very Germanic cardiac surgeon, great technician, on Saturdays we never did anything at the Brompton because there was no accident in emergency, no nothing. So the residents used to go to the pub on Saturday night. And about 9:30, when myself and the senior registrar had been in the pub for 3 hours already, there comes a call that an American Air Force jet is bringing a lad from Iceland with a transected thoracic aorta for urgent surgery, and Paneth is coming in to do it, so could we get ready? And I'd had about 4 or 5 pints of beer by then, and so had the senior registrar, a nice Welshman he was, and so I thought, shit, am I in trouble now? Because I'm not going to be able to stand there for 3 or 4 hours after several pints of beer. So with Lord Brock's boots, I thought, I've got a plan. So I went to the ward and got some Paul's tubing, and I changed into my theatre gear, and I attached the Paul's tubing to my private parts and let it down the inside of the trouser leg into Lord Brock's boots. So I was assisting with this transected thoracic aorta at 2 o'clock in the morning. The senior registrar had to keep running out. And Paneth turned to me and said, "Westerby, what's wrong with Rees? He's been in the pub, hasn't he? He's been drinking." I said, "No, Mr. Paneth, I don't know about that. I've been in the library working all night." And that's how my cardiac surgical career started because I stood there stoically, slowly filling one of Lord Brock's Wellington boot. That's in my next book, actually. And there, this was another great thing. Grunzig started angioplasty, and then flew his plane out into the night and disappeared one night. And angioplasty had a massive impact. It didn't actually decimate coronary surgery that much, but it did have a sizable impact. And then I went to Alabama. I went from Hammersmith to Alabama. I told Hugh Bentall in the old days, I said, I want to go train in America because, nothing happens here in the UK. I want to go train in America. And I said, I want to go to Shumway. I want to do heart transplants. And I was told, Westerby, you are completely undisciplined. If you go to Shumway, who had a reputation for other things, you'll be even worse. You've got to go to Dr. Kirkland and he will sort you out. And that's what I did. And I landed in Alabama as this fantastic project on damaging effects of cardiopulmonary bypass came about. Jim Kirkland, the boss's son, was put on it to work with me. So I went to the operating room all day, and then I went to the lab all night and did all the experiments. And we found that complement activation, white cells and stuff, white cells stuck in the lungs, which was what was giving you the lung dysfunction. And we wrote a very fine paper about it. And needless to say, Dr. Kirkland put Jim's name first and mine second. But the great thing about that was I broke down this Bentley oxygenator and put every material in it, nylon from the membranes and everything else, into a test tube, incubated it with blood, and we found that nylon activated complement like crazy. So when we told the manufacturers of oxygenators that this was happening, they took the aggressive materials out, and that made cardiopulmonary bypass a hell of a lot safer. And it really did change everything. When I came back to the Hammersmith, I was looking for something, a drug to stop the activation of white cells and their release of protease enzymes into the lung, which was what were free radicals and protease enzymes were causing the membrane damage in the post-perfusion syndrome. And the only thing I could find to do inhibit those systems was aprotenin. So at the Hammersmith, as you know, we put aprotenin into the heart-lung machine and then saw that the operative field was very, very dry. And that's how aprotenin came about. And, in my view, aprotenin should never have disappeared in the way it did. It was a good drug. Then, when I went to Oxford and started cardiac surgery in Oxford, there was nothing there, no intensive care beds, no ward beds. So we had to do something completely different. So I decided that patients are not going to go to ITU. They're going to go to a recovery area and go back to the ward in the afternoon. We started Fast Track. And this is where I first came across Tyrone, because Tyrone didn't believe any of my data. So he sent nine of his people to Oxford to look at Fast Track. And it was this very nice young lady that started it. But we really did used to have coronary bypass patients sat out in a chair in the afternoon after their operation in the morning. One feature of my career, I guess, is that I don't look as if I operate fast, but the bypass times were all very short. And that's what really allowed us to just sit people up and get them through. But it worked. I'm not going to go on and on and on. I've got thousands of slides, but this for me was important. When I was in America, Rob Jarvik said this about artificial hearts. I went to see Dr. Cooley soon after he put in his second total artificial heart in 1981. I told Kirkland I was going to see Dr. Cooley because I wanted to see the artificial heart. What Kirkland said to me was not repeatable, but I went anyway. And I flew to Texas from Birmingham, Alabama, and I sat in the entrance of the Texas Heart Institute waiting for him to come in the morning. And I spotted him come in, and I rushed over to Cooley and said, Dr. Cooley, I'm a surgeon from London. I worked at the Brompton. You worked at the Brompton. I want you to show me the artificial heart. And he did precisely that, and he was absolutely charming. And after that, I had an association with him. And when the Texas Heart and so on couldn't, Bud Frazier by now, couldn't put in the TCI as a permanent device, they thought it was an excellent bridge to transplant device, but it would make a permanent artificial heart. They brought it across to Oxford, and we started a program. And we did rather well, and that made me massively, massively unpopular with the transplanters who thought that this was outrageous. But the thermocardia systems people, Thoratec as they are now, they're very smart. The new surgeons were not that smart, so they put arrows on these devices to make sure we put them in the right way around. The next thing was, I was interested, I set up a lab, a large animal lab with sheep, because the only way you could make smaller artificial hearts was if they were non-pulsatile. So I started to look to see whether humans needed pulse in the circulation. And to cut a long story short, with a sheep, if the sheep didn't need pulse, and we had sheep with no pulse at all for more than a year with the Terumo VAD and the Jarvik 2000, we showed that continuous flow pumps were safe. So in 2000, I did the first permanent implant of the Jarvik 2000, which was the first permanent implant of a non-pulsatile device. And good old Peter Houghton here, you can see the trophic changes in his feet. He'd got a hugely swollen belly, his nose is blue. Philip Poole Wilson came up from the Brompton the night before surgery to guarantee that he wouldn't live another 6 weeks. We put in a Jarvik 2000 and he lived for 7.5 years. So that was the era of the new devices. And in the lab with Jarvik in Oxford, we worked out this way of putting power into the body, because the bugbear of the bigger devices was driveline infection. Cochlear implants didn't get infected, so we decided we would put power into the head and screw the pedestal into the skull so it didn't move in relation to the skin. So, I mean, that made me the first real Dr. Frankenstein. Yeah, I actually was putting power into people's heads, and it worked really, really well. The Americans wouldn't do it because it meant that 2 surgeons had to be paid for the same operation. But it still works well, and only the Jarvik has it. And then, of course, we showed that transplants and rotary blood pumps were eventually producing virtually the same survival time. The big problem in most countries is this costs the same as a Porsche car. This is Peter Houghton and another of my patients. I said a program called Your Life in Their Hands stimulated me to be a cardiac surgeon when I was 7. 50 years later, the BBC rang me and said, we want to make a program called Your Life in Their Hands with a heart surgeon, a brain surgeon, and a transplant surgeon. And would I be the heart surgeon? So I came full circle and implanted a Jarvik live. And this was the patient. And he did very well, went back to Scotland, went out one day, Christmas shopping, and forgot to take a spare battery and didn't get home. So these devices work. And end of the story. So because we couldn't afford American devices, I set up a company with motor car engineers, and we've got a very, very good British device now, which will be ready soon. We're getting to the stage in cardiac surgery where it's a bit like this. The cardiologists want us in this position. We can fight back, but perhaps we're not making as good a job of it as we should. This is the very last slide. Successful cardiovascular surgeon should be a man who, when asked to name the 3 best surgeons in the world, would have difficulty in deciding on the other 2. Quote Denton Cooley. They weren't together. He sneaked up behind Dr. DeBakey at a dinner one day because everybody wanted a picture of the 2 of them together. and DeBakey wouldn't have Dr. Cooley anywhere near him at the time, so they got this fabulous picture of the two of them. And as you know, eventually they all came together. Thank you very much.